as the minutes tick away. Welcome to the, I had to think I was going to say October, but we're not October, we're in September, Primary Care Commission Committee meeting. And just a reminder, the meeting is being recorded and it will be on the CCG website afterwards as well. So I would be grateful if everybody has their cameras on so I can see some faces rather than blank screen, and if you can mute your microphone while you are not speaking just to reduce feedback. But I'm sure you all know this, but I thought I'd just repeat it just in case we've all been on holiday and forgotten what we have to do. I think that's wishful thinking. We took a chair's action, actually it was the voting members together. We took an action in between this meeting and the August meeting on the additional roles in Norwich PCN, and I think that's included in the papers that has come out to everybody. Apologies, we've got a few. We've got Jason Horridge, Kev Byford, Sadie Parker, Shepherd Newboob, Mel Benfell, sorry, Rosemary Moore, Jude Bowler, and also Health Watch Suffolk. I think there's going to be a bit of shuffling around on the LMC this afternoon for different agenda items. So Naomi's with us at the moment, and then I think she's going to dip out, and Nikki Watson's going to join us for items 9 and 11. And then Johnny Graham's going to do that, join us from 12 to 13, and then Naomi will miraculously reappear for the rest of the agenda. So if you see a lot of movement, that's what that is for. The declarations of interest, can I just ask whether there are any interest to declare that's not already on the declarations, and also to remind everybody to keep the declarations up to date, including for close family members as well. So I don't see any hands, so I will take it that there is nothing additional to add to that. So on to the minutes of the last meeting. Sorry, I'm just got to look at my papers. I take the minutes as read, and are there any corrections for factual accuracy or matters arising that is not in the agenda this afternoon? No, I think so. I will take that as the minutes are approved as they stand, and we can move on to the forward planner, which is, sorry, I'm just moving between, I think it's at the front of the, no, it's not. Sorry, it's just here somewhere in the pack. Forward planner. Yeah, sorry. Just on to, actually, no, sorry, I skipped the action log. There was an update on action number 60, which was sent out to everybody, 61, to everybody in the meeting prior to today. I don't propose to read it out. So 61 is in relation to there was a question raised in July about the training hub, and so some work is being done on that. So I'm just going to go through the action log just in order. 37 is still outstanding. We're waiting for NHS England to come back. 51 is on the agenda this afternoon because it's a digital update. The Learning Disability Health Check is closed. In the number 59 about PCN development is, I think that's ongoing it's a PCN assessment. That too is actually, I think, on the agenda for this afternoon. The 61, we've had the update via email on what's happening with that, and there's a later date for the Training Hub to come back to us with more information. And the other two, 62, 63, are for the future. The Coat Ashore CQC report number 64 is that is with the team looking at coming back to just report if there is anything to report. 66 is closed. 67 again will come back to us with the Training Hub, and then the next two items, 66, 68 and 69 is closed. Number 70 is on the locally commissioned service about checking with Norfolk County Council.
I do have an update on that, Doris, sorry.
Thanks.
If that's okay.
That'll be good.
So just quickly, thank you. And so we've had feedback from County Council colleagues that they'll be leaving things the same this year, and that it's likely they'll be commissioning other providers to support with the backlog work. So we will continue to update going forward, and there will be a full review in the new financial year as well.
Okay.
So I think we can close that, but we will bring updates back in future meetings, of course.
Thanks, Mark. So that's updated and we can be closed. And then 71 is a GP survey, that's can be closed. And 72, I think, is still open. And 73, again, can be closed as a GP access survey. So that's the action log. Are there any questions, comments on that? No, thank you. So on to the forward planner. So we are in September. I think everything's on track apart from the terms of reference, but that is sitting with NHS England at the moment. So I don't think there is anything to worry about on there. Unless I've missed anything, Fiona? No, excellent. On to the item 6, which is the risk register. I think, Mark, are you taking us through this one?
Yes, Doris, if that's okay. So I'll take the paper as read, but just to flag really 4 risks I'd like to flag. So obviously the 3 red rated risks around the learning difficulty health checks, the prescribing of hypnotics in primary care, and it's classed here as the knock-on effect of other providers not reinstating face-to-face appointments. That or we've talked previously, haven't we, about shift in workload across providers. So there is still much work. I suspect as part of the course of today's discussion, some of these will be touched upon in the course of discussion, and some of the items that are coming up. So they're the highest rated risks. But one I think that we are acutely aware of, an amber risk at the moment, is about the general resilience of primary care. We are seeing more and more cases and more pressure that's being, as with many services, I should say, across health and care. There is an awful lot of pressure on primary care services, and the resilience of primary care teams at the moment is something that the teams are focused on and trying to support where possible. So I probably won't say too much more than that, but very happy to take any questions.
Thanks, Mark. Are there any questions, clarification from anybody for Mark? No, I think that's it's good to have the updates, and it's also quite a lot of those items are actually on the agenda as this afternoon as well, so we can take it there. Thank you very much. And you again, Mark. I think it's just an update from Sadie.
Indeed. So just a few new items since the last month's meeting. Thank you. So first of all, I've said in my report, and I won't go through it verbatim, but it was we had a really good session at HOSC this month where we focused on the vulnerable adults service and supporting vulnerable adults in particular in the Norwich area. But there's very useful questioning from members around how we best join up services supporting vulnerable people across Norfolk and Waveney. So that was very pleasing to be a part of that discussion. And actually, I think a lot of good ideas were discussed around how we might develop things across Norfolk and Waveney. So that was good to see. Last month, we talked about the pressures in primary care, and I suspect we'll do so again today. But just to say, later this month, we should be establishing an interface group in particular between the acute hospitals and primary care to really explore some of that work and some of those pressures that all people are seeing, and can we work better together to try and address some of that. For example, phlebotomy will be on the agenda, and bloods for the first meeting. And the final thing, just to say, and the paper does allude to, we know there's been an announcement just in the last couple of hours about the vaccine programme and how that will be rolling out in the coming months. That could have quite a big impact on our services. It's too fresh for me to be able to comment too much more than that at this stage, but that's going to be a significant piece of work for the system and indeed primary care. And as I've said before, I think it's really important that we support primary care, don't overload primary care. Primary care have been so good at delivering the great success we've had around the vaccination programme in Norfolk and Waveney, but there is also the, let's call it business as usual, that we can't allow to slip as well. So we'll be managing that very carefully over the coming days, weeks and months, and around the plans for that. Still some quite big questions to answer, I think, around co-administering of vaccines and things of that nature, because that will have a big impact on the programme. But I think it's important to note it here. So just a quick few updates and highlights, but very happy to take any questions.
Thanks, Mark. Are there any questions from anybody based on that paper? Kathy?
I'm not sure it's a question, it's a comment really. So at the weekend I was working at the Norfolk and Norwich. The last 2 weekends it's been clinically vulnerable children. First weekend it was kind of children who were physically sick, and then this weekend it's been children with learning disabilities. And the thing that struck me is for that client group, many of their appearances at the hospital have been extremely traumatic. So children were taking on average like 2 hours to get vaccinated just because it was just so difficult for them. And it did strike me, you know, I was talking to the parents and they were saying, you know, they'd be so much better if they were in the community or at the GPs where nasty things don't happen quite so horribly. And I suppose that the observation I made to myself is, yes, but, you know, thinking about the capacity of primary care, but on the other hand, the expertise and also the acceptability of that service for these extremely vulnerable children. So it was an observation, really.
Yeah, thanks, Kathy. First of all, thank you for doing it. And and we've had an awful lot of debate and discussion around this, and Karen may wish to come in as well. There's several aspects to this, isn't there? That's about where's the best environment for the patient and for the families, but also noting that some of the care needed for those individuals is more complex, and what's the best environment to support them, heaven forbid, should things be needed. So it's getting the balance right, isn't it? But Karen, you might want to add some.
No, exactly that, Mark. And, you know, our colleagues have been very, very good in terms of the acutes in trying to offer bespoke models. But Kathy, sometimes it is around the complexity of those children. It is safer for them to be in the acute environment. But thank you so much for what you're doing as well as a reservist. We'd be lost without you and your colleagues. Thank you.
Are there any other comments, questions, Mark, on this? No. Presumably with the vaccination and the announcement about rollout to 12 to 16 or 15, there's going to be some work needed with the schools programme as well as part of that, to add to the excitement of the mix. Just a question. I mean, there's a lot of coverage in the news about shortage of test tubes. Is it a major issue in Norfolk and Waveney, just out of interest and curiosity? There's lots of nodding of heads, yeah, so I take that as yes. And
yes, it is, and not just in Norfolk and Waveney. I think it's everywhere. I'm probably not best placed to answer that question, but I mean, sorry, I don't want to put you on the spot, Karen, but I know your teams have been linked, and Chris, are you able to update any more? If not, that's fine. And I'll...
Yes, it is a problem, and as Mark said, it's a broader problem than just the region. We are having to be very careful in the amount of blood bottles that we're using. There is a supply issue. We're working very closely with primary care and with our acute colleagues, making sure that we've got regular sit recs in terms of the position. The last I heard, and I have been off for a few days, was that they were hopeful there was a solution to the problem imminently. But it's not going to be a quick fix. It's going to be in at least a couple of weeks' time. Fiona, I don't know if you've had anything more recently since I've been off for a couple of days, whether there was any other issues since Thursday or Friday.
I've not heard of any. That's the latest update that I have, Karen.
thank you very much. Sorry to drop you into it, but it was just, it's in the news, and I think it's the impact on the workload on GPs as well, and patients needing referral, and it's just
it's been quite difficult for GP colleagues to determine what's considered an urgent requirement and what's not. So it's there's been lots of guidance, but even some of that guidance has been quite difficult to interpret, I think. But hopefully, as Karen and Fiona have said, within a week or two, we should be in a better position.
Yeah. Doris, can I just add here, this was discussed at the Quality and Performance Committee a couple of weeks ago. Mark Lim raised it as a red risk, and we have asked for it to be raised on the GBAF, at the governing body, because it is having quite a significant impact on primary care, not only in their ability to deliver their services, but also in terms of giving rise to more abuse for staff who already are in receipt of quite a lot of abuse. So it almost seems that it should be a risk shared across the two risk registers for the two committees.
That's great. If there's no other questions, can we move on to item 8, which is the primary and secondary care interface? Is Lois joining us for this, or is somebody else taking it?
Lois should be joining us. So
Shall I dial her in?
Yeah, I think what we might do is go on to item 9, and then Lois can join us, and I'll just swap the agenda items around a bit, rather than us all staring at our screen, if that's okay. So we sort of jump to item 9, which is the paper on locally commissioned service. Mark, are you taking this?
So again, I think it's still the timings, isn't it? We're a bit ahead of schedule. I think Gina's supposed to be coming to that one as well. So sorry to be a pain, but could I suggest we perhaps move to 10 with Fiona here? Would that be okay? And we'll contact Gina and Lois to join.
No, that's fine. Last month I was running behind time. This month I'm ahead of myself. I must have put too much coffee in my coffee mixture. Yep, that's fine. So we move to item 10, and then we'll go back to 8 and 9. Thank you.
Thank you. I was going to do a general update on PCNs, and then we're expecting Mandy Wegg to join us to give the South Norfolk Spotlight report. So Sarah, I don't know if you can see if Mandy's around to give that update when I finished.
Yeah, I will do.
Thank you. So I just wanted to give you a quick update. Can you move on to the second slide, Sarah? Thank you. Since we last reported to PCC, there's been quite a lot of action taking place. We had hoped to present the key themes from the PCN development plans for this financial year to this committee, but we're still doing some work on them. So they'll be presented at the next committee with the funding attached to the requests. The additional roles plans were submitted by the end of August, and we're waiting for the regional team to come back to us with a consolidated picture, and this will then illustrate how much forecast underspend and forecast spend that we've got. If there's any forecast underspend, then that can be utilised by other PCNs this year, and there will be I call it a bidding process, but hopefully not too bureaucratic, for other PCNs to bid for the funding, which will then be available until the end of March. There will be an update for the additional roles plans, forecasting what they intend to, the numbers they intend to recruit between now 2022 and 24, and those plans have to be in by the end of October. And obviously that will give us a much better picture and allow us to do some long-term planning in terms of how we support the additional roles with training development plans, and obviously we will come back to the primary care commissioning on that. The PCN plans have now been updated by the national team, and I'll go into detail about what's happening with those in a moment. In addition to that, we have been asked to put in place and confirm the arrangements for extended access and for them to be in place with PCNs by April 22. This is being carried out as a separate piece of work by the delegated commissioning team. In line with the updated guidance, the Impact and Investment Fund has also been published for 22-23, and that sits alongside the services that will be introduced. In addition, they've identified some additional funding to support clinical directors, and this is in addition to what's already available this year. So we haven't had a final confirmation, but we believe it to be in the region of about 800,000 for Norfolk and Waveney, and we're just waiting for that figure to be confirmed, and then we can advise PCNs. So with all those updates that will come into effect from the 1st of October, PCNs will be auto-enrolled, so we'll have to opt out if they choose not to go forward. Next slide, please, Sarah. Before I move on to what's happening in the future, you may remember back in earlier this year, we gave an update on the PCN development plans for enhanced health and care homes and the maturity matrix. And outstanding was an update on the structured medication reviews that was also undertaken at the same time. So what I've done here is to include some key themes, because there was a lot of similarity and common themes across the PCNs. But you can see there that the key deliverables in terms of structured medication reviews, the PCNs are being asked to deliver, and the progress that's being made. And I think it's fair to say, and maybe Michael will want to comment on this later, is that each PCN is at a different stage in their development around this work and in taking it forward. But certainly there's strong working relationship with the medicines optimization team, and sharing learning, and being able to update each other on what's happening across the system. Next slide, please, Sarah. So in terms of what's happening going forward, the services that are being introduced from later this year or into next year, the first one is the relates to cardiovascular disease. And from October 21, PCNs will be asked to focus solely on improving hypertension case finding, diagnosis, with further work for them to do from April 22, as you can see there, to look at increasing the diagnosis of atrial fibrillation and other diseases. I think a key part, and relates back to access, is tackling neighbourhood health inequalities. From October, they're being asked to identify and engage with populations experiencing health inequalities at PCN local level, and to co-design interventions to address the unmet needs of this population. And this is a lot of preparatory work in terms of delivering this from March 22. But I think all the PCNs are already doing this work. It's part of their improving access work that they're doing to ensure that patients can be seen, and part of their restoration plans. And this will continue through next financial year. Next slide, please, Sarah. And then the other two services, anticipatory care. Now this one has been deferred. It was due to start in October, and obviously there's an awful lot of work jointly with community care services in this. So PCNs will be working very closely with colleagues, and this will be supported by the CCG, primary care and community care teams working closely together to support them. And at the moment, we're waiting for some more national guidance on how this is actually going to be rolled out. But as you can see, we're looking at a year down the line. And then finally, personalised care has also been deferred. However, they're being asked to prepare to start work from April 22, which really is around expanding the role of social prescribers and supporting digitised care and care home residents. So PCNs will be doing this work between now and next April to prepare themselves. And the CCG will be trying to support them as well through the personalised care teams, but also the work regionally that's been done with social prescribers and at an ICS level. Sarah, excuse me. So helpfully, this is a very clear summary of what the key objectives are now for PCNs going forward. So on the left-hand side, you've got the key priorities, and then down the middle, you've got the different service requirements that PCNs will be able to meet those key priorities, and then the key investment and impact fund indicators, which provides the funding to allow them to deliver those key objectives. Sorry, Bill, I don't know whether you want to come in or if
I'm happy to wait till the end.
Okay. Sarah, next slide, please. And then this is a continuation, as you can see, the other two objectives, which is better outcomes for patients on medication and creating a more sustainable NHS, which have strong links back into the structured medication reviews. And if you then go on to the next slide there. So really the next steps for us is to finalise the plans for 21-22 and to agree where we can support as a system with recruitment and training needs. Then we also, and as part of that, obviously we need to determine where we need to link in with other CCGs to ensure that we deliver a system-wide approach to this. So that's picking up the relationships with personalised care teams and obviously community care. And then I've talked about the preparatory work that the PCNs are being asked to do between now and the end of March. And I think importantly, the other thing that we're keen to look at is the digital tools that are available, and obviously much of these will be covered by the report later in the meeting about what's available and how we can support PCN development and staff to work more effectively, therefore giving them time and space to care for more complex patients. So next slide, I think that's. Is there another slide, Sarah?
That's the last one.
That's the last one. Thank you. You take it down. So I'm happy to take any questions.
Bill, do you want to come in?
Yes, I suppose looking at it from an outsider, social care and obviously primary care under all parts of the system under immense pressure as a result of COVID, but the anticipatory care and the personalised care I seem have been deferred, but they are really all about prevention, aren't they? And in terms of reducing pressure on the system, the fact that they have been deferred and they are probably going to be the source of reduced pressure. I mean, it's what happens with prevention because it's not in your face. But I'm just as a matter of principle from a committee like this, I would have thought that the prevention agenda, we should be opposing its deferral because actually it's all about making the system more sustainable and reducing pressure.
Yeah, I think that's a good point, Phil. I think the deferment is a national directive that's come down.
Well, I think that's half the problem with the system. I had a conversation with Anne Radmore when I saw her last week about that very point, and I'm not sure that it's understood to the same degree because every time one wants to talk about prevention, the issue in the acute seems to take precedence with waiting lists. So, if we have a degree of autonomy at the Norfolk and Waveney level, I think we should push it as much as we can.
Is there any wiggle room in terms of this at all, Mark?
So just to say, I completely agree, Bill. Prevention is so important, isn't it? Anticipatory care, and just to say, while the national DES may be deferring it, I don't want us to locally, more broadly across the system around, emission avoidance schemes, and a lot of the discussions and feedback I've had from Place are around the teams, the integrated teams, about what can we do to get ahead. So rather than dealing with the crises, as our inboxes and our day jobs seem to be very full of at the moment, I completely agree, but we cannot lose sight of the prevention agenda. And it's pleasing to me that actually people on the ground are still very much focused on that. Once they can get away from the crises, around what more can we do, how can we join things up, not just health and statutory care services, but voluntary sector, and working with district councils, and that for me is the exciting piece. So I completely agree. I think just because the national direction is this, I don't think that we are taking it as a right. We will pause that in terms of what we need to do as a system, as a Norfolk and Waveney society.
That's really great to hear, Mark. And I have one further comment that's sort of allied to that, is that if we're going to be doing more work with the local authorities and stuff, we have a very confusing set of names here, because we've got a Breckland PCN and a Breckland Council with different boundaries. We've got South Norfolk and South Norfolk in the different systems, and I just think when South Norfolk PCN's talking to South Norfolk Council, and vice versa, and the fact that some of the the boundaries aren't similar and stuff, I think some of this is going to get more confusing. So I think as a matter of principle, as a system, we ought to encourage names where different organisations don't have the same name. As we get more joined up, I think it will become more apparent.
Thanks, Bill. Tracy?
Yeah, my comments got a couple just going back to the structured medication reviews, and I know you noted, Fiona, that we did have different levels of progress at different PCNs. So just in consideration of that and kind of that impact of those medication reviews and how important it is, for instance, deprescribing where it's appropriate and falls and various things, in order to kind of not have any kind of unwanted variation across the patch, what kind of support are we putting in or help for those PCNs where they are kind of perhaps falling behind a little bit, as you indicated? So that's kind of my question. And then my other point in respect of the inequalities work within the neighbourhoods, I mean, it's really great to see, but the importance of ensuring it's kind of data driven. So what PCNs are focusing on is really where they need to focus. It's going to make an absolute difference in that regard. So that data is so important. I know that we've got the toolkits that public health has supported with. We've got the shape tools and various things. And certainly I know from Bill's perspective as chair of the Health and Wellbeing Board, and as myself as vice chair, we're going through a strategy refresh for the for the strategy to GSNA and various things. So I'm really keen that we kind of link this work up with what we're doing, system wide in respect of the Norfolk Health and Wellbeing Board, and of course the Suffolk one as well.
Thanks, Tracy. Who's going to come back and answer some of Tracy's questions?
So I think I might defer to Michael in terms of the structured medication reviews and how the team's being supported there. But I absolutely agree with Tracy in terms of using data. And I think the work that's been done recently over the past year or so has really illustrated how we can use that information to target patient groups. And so, yes, it's population health tools and data is going to be a really important part of the work that's being undertaken.
Michael, did you want to come in?
Okay, yeah, I've put my hand up about certainly structured medication reviews in general. It would be useful if we, because PCNs are still, pharmacy teams are still developing, and my team are, still developing relationships and suitable fora to help with, getting everybody lined up to do similar things in terms of priorities for our population, which there are quite a few of. And it would be really useful to align those to our prescribing quality scheme, etc., and use similar tools. So in South Norfolk at the moment, the NHS pathways it isn't being used. It would be really useful if NHS pathways was used by the whole population. And there's a module in there called SMR Live, which identifies patients for you and gives you hints at what needs reviewing. So it would be really useful if those tools were consistent. So certainly we would favour, a suitable fora to have more input into directing and helping and prioritising SMRs, given that different PCNs have different levels of experience, knowledge of delivering structured medication reviews. But the other thing I just wanted to temper was there was a section on identifying more patients with AF, familial hypercholesterolemia, and heart failure, which is a laudable aim. It is driven by the Academic Health and Science Network, which has very strong influences to industry and specific companies' drugs, and PCNs will be approached by drug companies offering tools to help identify those patients and services to get people onto their drugs. So just just a warning that that is very expensive and needs to be fully costed, and preferably a pathway agreed with the medicines team to make it sustainable.
Thank you, Michael.
Okay.
Karen?
Thank you, Doris, and thank you, Fiona. Really good presentation. In terms of the priorities that have been set, I can understand that they're sort of nationally driven, but for us locally, within the CVD category, I would really have liked to have seen something in relation to diabetes, because that is important for us as you know, within Norfolk and Waveney, and it's an area where we need more focus. I'm hoping there might be some wriggle room in that, along with what Mark was saying about what fits our local population and priorities, because to me that needs equal focus as well. But I appreciate we can't do it all. And looking at my primary care colleagues, I have no wish to push anybody too far, but I am concerned about the harms. And I think, you know, there's an opportunity with some of these around hypertension, around all the other checks, to be able to maximise the offer in terms of that opportunistic moment. Thank you, Doris.
Thanks, Karen. Could your presentation be just shared offline after the meeting? That would be helpful. There's quite a lot of information on there. My speed reading isn't at speed at the moment, so that's very helpful. Are there any other questions for Fiona? No. Right, I'm going to really confuse everybody by going back to the agenda, because I think Lois has joined us. So we're going back to number 8 and then going back in order, and then we'll come back to Mandy just to confuse you even further. So sorry, poor chairing, can't do timekeeping. So I'm going back to Lois on the primary and secondary care interface.
Thank you, Chair.
Right.
So I'll just run through a few key points from me then. So there continues to be significant pressures and challenges at the interface. This has really got worse during the pandemic, as we've seen secondary care use more virtual appointments. It seems to be shifting outpatient diagnostics largely from secondary care to primary care. It's been a bit of a challenge to try and quantify what that activity looks like. So we sent a survey out to practices to ask for 4 weeks worth of data and to try and get some understanding of what the pressure is. So far, we've had only 12 responses back, but it has overwhelmingly showed that phlebotomy is the big thing. It's in terms of workload pressures. I'll be bringing a paper back to PCCC next month to show that data in more detail, but also to look at other data sources from pathology, and with a set of recommendations as to what we do about that. We've got this critical period where before the LCS review concludes, where we will make sure we commission phlebotomy and primary care appropriately. We've got this period where we are not funding primary care correctly for this additional workload, and we do need to take steps to rectify that, because I think there is a risk that general practice may stop doing some of this work and patients will be left in the middle. Just to highlight a couple of other steps that we're taking to try and improve things at the interface. One is to launch a new process for all our system partners to raise interface issues through. So currently there is no one single point of contact for use. This will see a new digital form being used for all our system partners to raise these issues through. It will see also us being able to use a single point of contact for all our providers, which will be fantastic. We're also launching an interface group, which we hope will be set up by the end of this month. And this will be clinically led and see membership from all our system partners. And we really need that group because there's some really difficult things we need to work through as a system, and we need to recognise we've not got additional funding to keep drawing on. We've got money sat in block. We need to think differently and innovatively to solve some of these problems, such as this phlebotomy shift in activity. So hopefully this group will see all our system partners come together and start to work collaboratively and innovatively to try solving some of these really difficult issues. So those are my key points. Happy to take any questions.
Thanks, Lois. I think for me, I think actually the focus is on the patient, because, you know, as a patient and a carer, I kind of go, it doesn't seem logical to have to ship people to a hospital appointment when they can do it locally. It reduces the carbon footprint and the stress. So that's where I come from, and I hope that's not lost sight in any review that takes place. Anyway, I'll get off my hobby horse. Naomi.
Hi, yeah, thank you, Doris, and thank you, Lois, for that presentation. I think whilst we acknowledge everything in that report, and we're pleased that it also acknowledges the pressures general practice are under and a shift to work from secondary care, it's important to note that we are still in discussion with the CCG about the interface group and the document itself to make sure that it does meet the contractual requirements that are set out for such a group. But also just wanted to draw the attention to the current process of reporting issues, and we're continually receiving responses and practices that they're not having their concerns and queries responded to, and that whilst the work is taking place to put together this interface group, it shouldn't mean that work is being paused and waiting until that started, because these issues are happening daily and are a real impact on general practice. And I think going back to the points about the lack of blood testing bottles, these are proving to be a real issue with patients and GPs' relationships being strained, because there are things that patients are going to see their practice for which they shouldn't have been told to go and see them for, and then it's having an impact on the GP-patient relationship. So it really is vital that in supporting general practice, we are urgently looking at solving these issues. And whilst there is an issue with the reporting, that has led to practices being disengaged in the process. So the full picture is really difficult to achieve because practices have almost given up on the process that's in place. So I think whilst you're acknowledging there haven't been as many reports as you would expect, I think it's important we focus on the fact that that probably isn't a true reflection of what is actually happening in general practice, and it is a real issue.
Yes, and I think in my paper I did pick up the fact that the process that replaced QIR has not been fit for purpose, and absolutely aware of that, and we have taken steps in the last couple of weeks to make sure we are putting a proper process in place and practices issues are being logged and responded to. But acknowledge we had a time frame of months where practices were submitting issues and we were not appropriately responding to them. So that is being picked up and addressed.
Thanks, Naomi. Thanks, Lois. Bill?
Just in terms of, are there pockets of good practice that could be used to encourage change of behaviour, or is the picture uniformly dire across the whole of the system?
Thanks, Bill. I think we need the interface group to discuss this, because I think there may well be some pockets of good practice. I think overwhelmingly what we're hearing is the activity that's passing to primary care is just overwhelming. They're not being funded for it. We need to do something very differently. But I think out of that will come innovation and doing things differently, because we have to. And there will undoubtedly be good ideas that come from general practice and other system partners. But I'm not aware of examples that we can pull.
Have we asked anybody for a positive experience? Because if it exists already, it's more quickly adopted than having to start from scratch again.
We haven't. The big issue is the funding, and it's, as always, it's trying to move the funding with the activity, and it's always tricky to move the funding in this case because it's strapped in block to primary care, and that seems to be the blocker with where we need to think differently on how we do things.
John, did you want to come in on this?
Yeah, just a couple of comments if I may. So first of all, very much welcome the setting up of this group, because there's a lot of thorny issues that need to be worked through, aren't there? And also welcome the line that Lois has mentioned on the funding, because that's absolutely correct, that there isn't extra money to put into this. Unfortunately, we're a system with a very significant financial deficit, so we're not going to be having a lot of extra funding for many years yet until we can get out of that financial difficulty. having said that, clearly we need to recognise where there are additional costs in the system. And I think that's the nub of this, really, that in the past we might have thought about work moving from an acute provider to primary care, and therefore we changed the contract with the acute provider to take the money out. I think the reality will be they're still incurring the same costs. They've got pressures, and this is one way of them relieving those pressures. Not necessarily the best thing for primary care, of course, and not in a planned way, but their costs are still the same. So as a system, we could take money out of the acute, but that doesn't really solve anything, because then they've got a cost pressure due to something else. So it's about, as Lois said, doing things differently, seeing how we can make better use of the money that already exists within the system effectively. The other comment I was going to make is that I think the system clinical strategy will be interesting in this respect as well, whether that says much in terms of the views of the clinicians in the system about where work's done at the moment and where it should maybe be done in the future. And I don't know what that's likely to say, but I believe that should be concluded in the next kind of 2 or 3 months. So it'd be interesting for the work of that to tie into the interface group, I would have thought.
Thanks, John. Naomi, did you want to come back in?
Hi, sorry, yes, just to come back on that one point. I just think it's important to focus on, we seem to be talking about funding a lot, and obviously that is an area that needs to be considered, but some of the shift of work isn't about increased funding needed for new services. Some of this work is shifts of work that are already within the hospital's contract and they should be doing, that are now being asked of general practice to do. So it's not about necessarily having to fund new work, it's about holding secondary care to account to deliver on their contract in some areas also.
Thanks, Naomi. I think
are all 3 acutes behaving in the same way?
Yeah, largely, yes, and it is because of this virtual appointments that have come back, which, you know, going back to the Chair's point, it's in the best interest of patients often to receive their phlebotomy at their local practice rather than have to travel to secondary care. But the issue is obviously that our trusts are in block with NHS England, so we're not in a normal contractual arrangement, and it's very tricky. It's a very difficult situation that we're in. That's why we have to think differently, and we have to get that buy-in from our providers to sort this out together. We can't just go, well, you trust, you need to sort yourselves out, and you know, it's different conversation.
And also I think it sort of feeds into the work of the ICS, because actually as we are going to succeed as an ICS, we need change in terms of how we think. Working as a contractual relationship is not going to be helpful in the long term. Although legally that's probably, you know, valid, but it's about building relationships. Hein, did you want to come in?
Yeah, Lois, thanks for the note and the update. But building on previous points, but how empowered will this interface issue group be? How senior is the representation? Can members make things happen, or do they have to turn to their own internal bureaucracies?
So it's all medical directors attending, or in some cases a nominated deputy, but they're pretty senior bods. But we have gone for a clinically led group because we felt that was appropriate. The LMC are also sitting on the group, and then we've got 3 GP representatives also. I mean, I suppose the proof will be in the pudding, and we have to see how it goes, and if it's not actually gaining any traction, then we'll need to review the membership, and we might need to get some more operational support in there.
No, I recognise a lot hinges on behaviours, but it's good to hear the senior representation there. Thanks.
Thanks, Mike. Thanks, Lois, for the update, and look forward to the next iteration, and hopefully there's going to be some movement and progress so that as a system we are actually working better together for the benefit of patients. Thank you very much for that.
Thank you, Jane.
Thank you. Right, I'm going to move on to item 9, which is the locally commissioned service. I think Gina's with us.
I am, thank you, Chair. And thank you for having me to the meeting. As I assume, everybody has pre-read the papers. I won't go through it line by line, as I'm sure you don't need to, nor do we have the time. I want to bring your attention to some points on page 3 with regards to the key principles. So the LCS review, as you're aware, is well underway, has been ongoing for a little while now.
And at the last meeting in August, you approved the 6 key principles, which we are using to underpin the review going forward, and the kind of the foundation blocks really of everything that we're looking at to go through. We have, since the last meeting, been finalising the financial scope of the project, going through with our finance partners and working with our clinical exec committee members on proposing groups of practices, groups of services. Previously, there's 38 individual service lines in there. We're looking to reduce these down. In order to be able to go through and ensure that these are clinically led, we are going to be assigning or have assigned members of the KEC to each of those groups, along with operational support and CCG members, finance, BI, quality, in order to go through and ensure that each of the programme groups are online and on point. We are very aware that the timescale is very short, as although we've had slippage at the beginning of the project, the end date of live for the 1st of April next year is fixed, and is something that we need to adhere to. So in order to move this forward at pace, we have papers going to the LMC committee today for their next committee meeting to review the proposed groupings, the proposal we have put forward and how we should undertake this review, and the timescales involved. And on the back of the recommendations, I should be bringing a paper to you in October for approval on next steps. We will also then be commencing communication with our practices. We're not sure at the moment how far they are really aware of the timescales, as we have had a number of false starts over the last couple of years on this project. But it's at a stage now where we do need to take it to conclusion. So we'll be working with the LMC again on joint comms pending their committee meeting next week. And we should be bringing some more papers to you in the October meeting. Any comments or queries?
Is there any questions, comments from anybody? No, you've beaten us into silence. Good luck with the work, and I look forward to the paper in October for approval to move it on. And yes, as you say, it's been going on for a while, and we need resolution really. So thank you very much for that. I will let you get on with the rest of your day. Thank you. Mandy, we haven't forgotten you. You've got the South Norfolk. We're back on track on the agenda. So South Norfolk spotlight.
Okay. Thank you, Chair. You can see you've had the paper, which I think Sarah's kindly shared. We have our challenges within South, not least our rurality, but certainly the sizes, varying sizes of our PCNs, with SNP the largest at nearly 85,000 and spread between Loddon and Attleborough, so quite a big stretch. So certainly for the programme, the COVID vaccination programme, we've had quite a few rural challenges there. Just picking out some of the highlights and successes and challenges. The mental health project, which we were in collaboration with NSFT, were funded for 2 mental health nurse practitioners as part of a pilot scheme in the Thetford surgery. So one based in Grove surgery and the other was in Watton. So very, very different pilots, but we were able to gain an awful lot of information. So with the funded roles, with the ours, with the additional roles recruitment scheme, it was able to give us a little bit of a base as to what to expect of those nurses. Certainly from the very beginning, that the expectation from them was a 30-minute consultation. The expectation from primary care was 5 minutes. So we ended up meeting somewhere in the middle. So there were a few bumps in the road to start with, but it was a really successful pilot, especially with the high amount of care homes in Watton. The mental health nurse scheme worked really well there and as an outreach. One of the challenges we had with COVID was the use of practices for a vaccination site. So we've seen quite an increase in patient feedback. Certainly the Humbleyard group has 3 practices, Heatherset, Mulbarton and Cringleford, and the Cringleford site was used for the KEC's vaccinations, which worked really well. The location was good and there wasn't the same rural challenge, but it did mean that patients who would ordinarily have gone to Cringleford for their consultations had to travel to Mulbarton or to Heatherset. So that gave us some challenges, but it worked well. And certainly it taught us to stretch ourselves, because anybody who knows the Cringleford site knows it's quite locked by other properties around. So we were worried about access and egress and the 15 minutes wait. So it was a large challenge, but it worked well. And certainly for the booster programme, we're going to move that to another practice and deliver it in a different way. So Cringleford patients did feel the pinch for that, but it certainly worked well anyway. And another one of our successes has been the Mid Norfolk PCN has gathered together some of their funding, and the GPPO, South Norfolk Health, has provided a visiting nurse scheme, which is shared equally amongst all of the practices. And again, this has worked really well, because there's now extra stretch on primary care from discharging patients from the acutes with assessments and palliative care and end of life. The visitor nurse scheme have been a really good cohort of individuals to make sure that this has worked well. What we have been looking at, and it's been more challenging certainly through COVID, because we haven't visited practices as we normally would, we've been looking at patient data from the patient surveys to try and gauge where things are. And if you're happy, I'll share a PowerPoint with you just from some data that's given us quite a few challenges, which I'll explain. Is that viewable to everybody?
Yeah.
Yeah. So within the Harleston surgery, and we've had quite a lot of feedback about access to the surgeries, whether it be telephone, whether it be turning up on the day. And Harleston, nearly 2 years ago, were the outrunners to say we're going to follow a total triage model. So you can see the issues with access back in 2018 was at 32%, but slowly that's grown, and they're now to 69%. And across the CCG, it's 71% is the average. So they've managed to climb. We'd certainly like to see it a lot better, but they've adopted a model where the patient, every patient rings in, they're then either contacted back by a clinician or contacted back by a receptionist or administrator and given an appointment. They're also reviewed for medications. So if it's a prescription, it will save them a visit and save a consultation. So it's been a hard trawl for Harleston, but you can see the success within the patient data. Within Orchard surgery, we've had quite a few issues with them and reports that access for them is more difficult. It's currently sitting at 56%. We're working closely with the surgery to find out what those challenges are. Every surgery now has an open door with a temperature check at the doorway, so all surgeries are open, but we managed to triangulate this with data, for instance, attendance at A&E or unplanned emergency admissions, because if it's difficult to access, then patients will access that care somewhere else. So we are now working closely with Orchard. There's a new practice manager and some changes in staff, so we're supporting them. The Watton surgery, you may well remember, went through a recovery phase, and we gave Watton an awful lot of support. They were the first PCN to actually work in collaboration before the PCNs were developed. So their back office, their GPs, it's one contract across all of the 4 contracts that we have. So we've got Watton, we're really struggling, down at 41. They're now up at 54%, but still some more work to do. Now, Heathgate surgery is one of the better surgeries, and I think Hingham was the only one to come out with 100% in 2 of the 4 years. But Heathgate have got the totally different model to Harleston, in that they book patients' appointments just as they would have done before the COVID pandemic. So they have a face-to-face model, but you can see that 89, 92, and then back down to 89 again. Now, we've compared this with similar surgeries. So Old Mill, which is just a mile or so down the road, has similar data. But looking at the overall performance data, there's differences. So it's whether the triage model is best for patients or not. Now this one, and you'll be aware that we have had an inadequate CQC report for Churchill surgery, but interestingly, their access, patient access, has come back really well, and their overall happiness with the surgery has come back really well. So what it has done is raise queries with us to say, actually, Churchill on paper and from a patient perspective looks really well, but at the moment they're inadequate in 3 domains. So we've tried to triangulate the patient feedback with the data, with what's happening with the surgery. So it's probably opened more questions than answers, but more questions is good because we can dig a little bit deeper without being able to face. So that's just a little snapshot of South Norfolk.
Thank you, Mandy. That was really interesting, actually. The especially the data bit and of the individual surgeries and different delivery models. Anyway, I should open it up to questions from anybody. John.
Yeah, thank you. Just following up what you just said there, Doris. Yeah, it was interesting to see those examples of the individual practices, Mandy, and I suppose just an observation that even those that have improved quite well over the last 2 or 3 years were still at pretty low rates actually compared to some of the other practices that you reflected. I think 54, 60% compared to 80, 90% in others. So I suppose just wondering within the practice in total, is there sharing of learning, sharing of processes and approaches to try and have that kind of mutual support for the practices that are maybe struggling a bit more? Because if only 50% of patients are saying they can get through relatively easily, that's not particularly good.
No, it isn't. No, you're right, John. The numbers are still low. What pleased me, I think, with all of them was that they were on the right trajectory, that they were coming back, although albeit slowly coming back. And we also don't know how much of the sway there's been recently with COVID. So I think some of the improvement could be hidden because of the access of the COVID patients. So I think out of COVID, if hopefully we are next year, that hopefully we'll see the trajectory continue and see some more improvement. But this gives us now the ability to look at somebody like Hingham as a small surgery and Churchill are both doing exceedingly well. Some of the larger surgeries like Orchard, for example, isn't. So is it around the administration process? Is it around not having enough receptionists? Is it around enough lines into the surgery? Have they got their staff mapping correct, at the right time of the day? So I think it's a combination of all of those. So if we can find, so with Heathgate, which we know works really well, we'll have conversations with the practice manager there, take some learning from Heathgate to Orchard to say, let's try it this way. And certainly all of the practices are up for support. They're all exhausted, obviously, because of the amount of pressure at the minute, but they all want to succeed. So yeah, so we're with all, not just access, we're looking at all of them and comparing 2 similar demographic areas and sizes to take learning from one to the other.
Thank you.
You didn't just say Kathy, did you?
I did.
I'm sorry, you went completely silent, so I saw your mouse move. So sorry. Okay, so a couple of things. I think the first thing is just reflecting on the access data. As John said, some of it is great to see things improving, but some of it's coming from a fairly low base. But what I guess I thought about was, when a practice gets a poor CQC rating in an area, sometimes it can be, a couple of policies are out of date or that kind of thing. And I thought that, when we take the practices at risk reports, it's quite handy to be able to consider other data, which genuinely does put patients at risk, and access data is one of those things. So that was my first comment. I guess my second comment is, in relation to the mental health specialist nurses and the difference between a GP expectation of a 5-minute consultation and the nurse's expectation of a 30-minute consultation. I know GPs for a long time have been held to ridiculously short appointments, and I think there's quite a lot of evidence to show that that's not the most effective way of going about things. I was talking to a district nurse the other day who is still subject, in our patch, who's still subject to having, you can only have this long with a patient, and also those patients are allocated by a non-clinician. So actually that person's not aware of how much or how great the need is of the patient. So I guess my observation was, as we move into PCNs developing, having more integrated teams, more integrated ways of working, rather than using this kind of reductionist approach of thinking about patient care, should we not be thinking about allowing professionals to use their judgment about how long it takes? Because I think there's a lot of evidence to show that that's the most effective thing, not just for patients, but for professionals as well.
Yeah, I absolutely agree, Kathy, and certainly the expectation, and bearing in mind this was a shared project, so this prevented first appointments at an SFT, so they were within surgery, but actually what the GPs didn't really recognise is the fact that this was better for patients in an environment that they felt safe in and familiar with. And actually, if it was a half-hour appointment or if it was a 60-minute appointment, the overall benefit for the patient and ultimately the practice is tenfold. So, and that's why eventually it was a 50-minute, but you're right, it should take as long as it takes. And a mental health patient wants to be heard, wants to be, listened to, so they need that time. So, yeah, it's finding the balance, isn't it?
Thank you. Andrew?
Yeah, thanks. Hi, Mandy. I'm here with a Healthwatch hat on this time. And it's the feedback we get from patients at Healthwatch. Partly, there's a lot of comment about access, certainly, but I'd just like to point out that the long-held stress, really, between the advantage of quick access and how that impacts on continuity, because it's all very well having quick access, but you have to make sure that you see the right person, and ideally the same person you saw last time. And patients really value that. And there's loads of good evidence to say that it produces better outcomes. So I don't know whether you've got any thoughts on how you balance that up. If you do, that's brilliant. And the other thing is just to say from Healthwatch, we have a community development officer for the South. And if you like, I'll put you in touch.
That would be brilliant. Yes, please. Thank you. Yeah, thank you, Andrew, to the latter. To the former, I think the continuity care, and this is where, for me, telephone triage works better in that whoever triages the call can then look to see who that patient would normally see and follow that continuation of care through. However, there's also the element that on the day, if you need to be seen, you'll be seen by whoever is there, and then that continuation is lost. So I think for planned care, the continuation is simpler with a triage model, with the practices that don't have appointment systems the same as everyone else. Certainly for a practice like Heathgate, which is one of the few which offers all face-to-face appointments, and it's how do you manage that? I think the challenges are also now with the partnerships and the salary GPs. Not everybody's full time, so it's how do you then guarantee you see the right person on the right day? So there's lots of challenges. But yes, please, if you put me in contact with your colleague, I'd be grateful, Andrew.
Many thanks, Mandy. There's no other questions. Oh no, Nikki's come in.
Thanks, Doris. I just wanted to pick up on what you said, Mandy, about planned care. That's all well and good. The continuity, it's the urgent care, isn't it? That's very different than on the day care. And I think we've talked about this at this meeting before about how important it is to communicate with patients, particularly with the introduction of the ARS roles and other roles in practice, that whilst you might think it's a GP you need to see or is the best person to see, that probably isn't always the case. but it's the communicating of these roles, isn't it, and what they're for and how they can be used and why they're there to support the GP, not to block access to the GP. I think that's key.
Yeah, I absolutely agree. I think that the communications, you know, I'm from a communication background, and communication for me is key. And a lot of complaints that I'm seeing currently is just around the comms, that, you know, they're not knowing. Certainly, I would say 80% of what I've seen is I always have to speak to somebody before I can make an appointment. Why is that? So, and I think if we'd done that a little bit better, to say, actually, and we've not got a standard response, but as near to say, actually, we can make sure you see the right person that you need to see if you need to be seen. If not, we can save you a visit, you know, if it isn't. And the comms is key. It always falls back to the comms, doesn't it?
Yeah, and I don't think COVID helped us with that in some ways, because a lot of practices were forced into a triage model or using footfall. Whereas I was lucky enough to have worked in a practice before I took this role on where we did footfall planned. So we had the time to go through months, literally months of communicating with patients, of showing them dummy systems, showing them how it would work. And COVID didn't really give us that, did it? So I think that's added to a lot of the patient stress about these systems, you know, coming in overnight just like that.
Yeah, absolutely.
Right, thank you all very much for that. Thanks for the update, and we look forward to hearing from you again in a few months' time. Thank you.
Thank you, Chair.
Thanks. We're moving on to item 11, which is the Learning Disability Health Check report. Just taking this one.
Hi, that's me, Doris.
Hi, Sarah.
Hello.
Do you want to take it away, assuming the paper is read?
I will do. Thank you very much. Hello, everybody. I am representing Shepherd today, who was unable to join, unfortunately. Back in July, Sadie came along to inform you of the CCG's aim to develop a high-level plan to improve the uptake of learning disability and autism health checks across Norfolk and Waveney. So I've come along today to give you an update on the work that's taking place to shape and take forward this plan. Hopefully you will have had the opportunity to read through the accompanying paper, so I'll just summarise the main points for you now. As Sadie outlined to you in July, learning disability and autism health checks are a priority for the CCG as part of the drive to address health inequalities. You might recall that there are some specific challenges that we want to address around health checks, including inconsistencies around data and the overall uptake and quality of health checks across the system. So to give you a bit of an update, a small task and finish group was formed in August to start developing a structured approach to identify ways to tackle these challenges and allow us to provide targeted support to any GP practices that need it. The task and finish group is made up of colleagues from across the CCG, including the quality and care team, the peripatetic team, the BI team, leads from each of the 5 localities, the delegated commissioning team and our wider stakeholders. Work is currently underway to finalise an overarching system plan to capture the initiatives that we can develop and build upon to improve the overall uptake. And localities are also working on their own local plans that will tie in with the system plan and provide a consistent approach where possible across the system. You might have noted within the accompanying paper that CCGs have been set a target nationally and this year to deliver a minimum of 75% of health checks. The comparative data that we have to the end of Q1 this year put us just above the national average at around 8.1%. So we're currently waiting for a refreshed update on our position against the national average, but obviously one of the challenges that we have is the data, so we know that this won't be fully accurate, and we're currently working to fix this. Data accuracy is one of our priorities at the moment, as we know from looking at last year's data that the system that collects and extracts the health check data, which is the CQRS, isn't very reliable. Sorry. Apologies, that had to happen. I'm so sorry. Sorry, where was I? A colleague from the BI team has already started working to really get to the bottom of the data, as this is one of our key challenges. And she's working with 2 local practices already to map how this data works within their clinical systems and identify issues that need to be resolved. She's also working to develop a dashboard that's going to pull together data from various different streams to give a much more accurate picture for us to work with. And as this piece of work progresses, we anticipate being able to receive more accurate data extracts much sooner, which will help us to monitor and take action to support any practices that need extra help much more quickly. Another area of focus I wanted to touch upon quickly is around learning, development and sharing best practice. You might recall when Sadie updated you in July, she outlined how all of the practices in our system have committed to delivering a minimum of 75% of their health checks this year. And we're aware that there's some really excellent work underway in the localities that we want to share across the system to support practices to improve their uptake. We're also working with the peripatetic team to capture and share their valuable learning and knowledge, and the CCG's training hub to look at training and development opportunities to support improving the quality of health checks, which is a really important aspect of the programme of work. The Task and Finish Group's aim is to complete the system improvement plan in the next week or so. Then we're going to do a prioritisation exercise to identify the key work streams and quick wins that we can take forward at pace. The proposal is to bring the final system plan to the PCCC for approval and then bring you regular updates on uptake going forward as the work progresses. It's hoped the committee will be able to support this approach, and if there are any comments and suggestions of how we can further strengthen this approach, they'd be very welcome, or I can take them back to Shepherd to feedback.
Thank you, Sarah. Are there any questions for Sarah? Tracy?
Yeah, I would just be interested to know, certainly the peripatetic team's been in place for a little while, so have we noticed any impact so far from kind of the work they have been doing in kind of our level of uptake, certainly knowing that a lot of the emphasis does lie on primary care, and particularly from my experience, I mean, with those people that have a learning disability, it's about making those adjustments, it is about making the experience nice, and sometimes it's not just about the health check, so I just wonder how much and what are we doing working with, you know, perhaps voluntary community sector organisations to kind of support, and that's kind of just different and innovative ways of doing things slightly differently, isn't it? And in fact, not always people coming to our surgeries, but going to people as well. So just some thoughts and how we're kind of embracing kind of wider stakeholder input into your Task and Finish group that have probably got some really good ideas for us as well.
Thank you, Tracy. Yes, we do have lots of ideas and initiatives of how we can work with wider stakeholders to link in with the people with learning disabilities and autism outside of primary care. And obviously one of the focuses will be what can we do to make practices more welcoming, so that people feel able to go along and have their health check, looking at sharing best practice on making reasonable adjustments, for example, and the peripatetic team obviously have a lot of knowledge and understanding that they'll be able to share, we hope, with the wider system on that.
Thank you. Bill?
Thank you. Well, I welcome this, and it's great to see some progress. So congratulations, and you know, I think it's been something that we've needed to deal with. A couple of things that come out from that, really, that it says final approval needs to come back to this forum, but the improvement plan will be ready within days, so we'll lose another month. it says mid-September and we're here on the 14th, so I'm assuming we're pretty much mid-September. So, you know, if we have just missed it, I would hope that we didn't just lose momentum and that's another month before anything can start. I know there's some prioritization work to be done, but I'd be keen if the committee was endorsing the approach that we don't lose even more time. And the second point really around the prevention point that I was mentioning earlier on, and this is a key prevention stream, and also we touched on this is a very difficult cohort to access, as we were talking about earlier about the clinic at the NNN at the beginning of the meeting. So I wonder if once this is up at a decent level of attainment and that the reach is far greater, it could be used as a way of programming in appointments or treatment going forwards, so that we can look at this cohort of people in a different way, and supporting what Tracy was saying about they are very difficult groups to reach. Getting them in a setting is not always easy, and actually the results on the patient take far longer if you take them out of their comfort situation. So I would hope that this would be the beginning of a wholesale change in the way that we look after this cohort that might well make it much more efficient to wear it and easier to manage and less expensive. So I hope we don't stop here, that we use this as the start of a more radical prevention agenda with this cohort. Oh, and one final thing, I know from my experience with social care at the county council that they're not equally distributed across the county. There are pockets, and so actually you're not dealing with all. I mean, there are probably 10% of the surgeries or practices that cover 80% of the people who are affected. So some of the prioritization could be like geographically based rather than across the county. So they're just my thoughts. Thanks.
Thank you, Bill. Thank you. That's really interesting.
John?
Yeah, thank you, Doris, and thanks, Sarah, for the update. A couple of comments I was going to make. First of all, just preface my questions, I suppose, with the fact, looking at the numbers on registers, I note that we've got a large cohort in Norfolk and Waveney in terms of learning disability patients. If you look at comparators with the other systems in the region, about the same as Hertfordshire and West Essex, we've got 50% more in their population at large than we have in Norfolk and Waveney. So as a proportion of our population, I think it's more of a challenge for us. Having said that, I suppose the question we're going to be, what's the extent of our ambition? Recognise that the target is 75%, but if we deliver to 75%, that's 1,500 or so patients that we're not giving a health check to. Is that acceptable? And also, how do we prioritise those, I suppose, that are receiving the health check? And in the context of the awful news that was published last week, does this programme include patients that are in private sector units, for instance, and would they be prioritised within the programme?
Thank you, John. That's also some really good points. Thank you. I will take these back to Shepherd for his consideration, but I don't want to speak for him, but I know that this area is very close to his heart, and he has worked in this area before, so I know that he wants us to sort of take this forward and use this as a starting point to really develop the work going forward.
Okay, thank you.
Thank you for the update, Sarah, and look forward to seeing improved uptake for the benefit of the patients as targets as a target, but actually is the greater picture of the people behind the numbers. That's the important thing. So thank you for that, and look forward to either seeing you again or Shepherd for the update on where we're going. And I take Bill's point about, we need to crack on with this, and no doubt if something's urgent, somebody will approach me to take chairs action or voting members actions, so we don't lose momentum. Thank you very much. Moving on to item 12, which is the digital update. I think Anne's joined us. I did see her pop up.
Yes, hello.
She's rejoined us. Thank you, Anne. Take the paper as read, and are there any highlights, lowlights you want to bring our attention before we open to questions?
Just that the digital team is busy as ever, trying to keep up with the ambition of practices for digital tools. So the clinical systems team is helping practices prepare for the flu and new COVID vaccination campaigns, implementing System 1 Care Home module and the hub modules for the additional roles staff. The N365 team is very busy at the moment with GP practices, trying to get the last devices installed, have the software installed, because support for 2010 runs out at the end of the month. So there's an imperative there to get that work completed. The care homes team is busy ensuring that all care homes and their associated practices and urgent care are all confident in using NHS mail, and everyone's got the care home NHS mail addresses to ensure there can be secure communication of information. And the Digital First Primary Care team is working on online consultations, re-procurement, and the optimisation work of online consultations continues. We are also working on the digitisation of notes in that team and procurement of video consultations. I know I had some specific questions from you, Doris, resulting from the paper. Shall I address those now? So I think you'd asked if our work with hearing impairment was linked to the non-spoken interpretation services procurement. Not as such, because we're not looking at interpretation, we're looking at enabling people with a hearing impairment to attend a primary care appointment independently. So we're more looking at tools like caption software, as well as the toolkit that's described within the paper. Things like masks with clear panels and vibrating pagers, and a whole range of things that we didn't know existed before. It's been very interesting to find out about. There is some AI interpretation tools for sign language being developed, but none of them in this country are quite there yet for trial. But that'll be an area to watch for the future. In terms of the footfall requests, there was a question about which ones are deemed not appropriate, and this is about channel shifting activity, really. So, for example, the repeat prescription request, which can be done via the NHS app or via online services, which doesn't then require practice intervention or an extra step for the practice. And cancelling appointments and booking appointments with nurses and things. So some of this is about restoration of appointments online to get to the pre-pandemic situation when those were available. And you also asked, is there a specific issue with EMIS as a system? And there have been significant performance issues recently. I'd say that the market in GP clinical systems is precariously positioned at the moment. We only have 2 viable providers. There previously were 4 until the GPIT Futures framework was developed a bit over a year ago now. And what we hear from suppliers is that whilst NHS Digital brings rigour to the process, that actually the process is too rigorous and the demands of NHS Digital too much for many of the smaller suppliers. So we've had no new market entrants to the GP clinical systems arena for multiple years now. Having said that, in answer to the specific question, I do think it is the right thing for this area to encourage all practices to be on System 1 because it is the predominant system and it brings a level of interoperability that we're just not going to see if we have practices on disparate systems.
Thanks, Anne. Are there any other questions for Anne on the digital update? Tracy.
From a practice point of view, thanks, Anne. I know how busy you've been, and it's been all the work going on, particularly with MJOG and Accurix and all that stuff. So I wanted to say thank you.
Thanks, James.
Tracy?
Yeah, just a question from me, and just thinking about patient choice. So I think within practices, we do maybe have a number of ways that patients can digitally access us, even particularly it might be Footfall, might be an NHS app for ordering prescriptions. And it's just wondering about, you know, have we done anything to discover what do patients prefer? What's their preference? What do they prefer to use? And I don't know if that's something Healthwatch could help us with, but I'm just thinking there are different choices, isn't there, for patients to kind of access in digital ways anyway. And it's also those elements of those that potentially digitally excluded, that we don't forget those people and what we can do to support and ensure that they can access, you know, primary care in the most appropriate way as well, which I know that your teams are doing, but that's always, I think, going to be a challenge that we mustn't forget.
Absolutely, Tracy, that's absolutely right. And certainly we believe that if we push as many people who can use digital solutions towards using them, then it does free up reception and phone time for those people who can't use digital access methods. And there is another reason that we're encouraging practices to get on board with the telephony project, because again that brings much more modern telephony. That one of our team rang the practice recently and they were 23rd in the queue. After half an hour they'd only moved up one place, so that probably means that there's only one line in and the person's dealing with the call end to end rather than moving callers on as they arrive. So a modern telephony system would allow them to do that. And you're right, there are a huge variety of methods, and I've been talking to practices and to PCNs recently about encouraging them to standardise on a range of tools that suit them to promote to their patients. You know, so for example, it's also about maximising the investment in the clinical systems. You know, so there have been lots of apps in the past. We've got the NHS app and we've also got the TPP AirMid app, which does give you more capabilities in terms of video consultations and online consultations, but we're encouraging practices to settle on one method of video and that sort of thing. Makes it easier to train staff as well, and new staff when they come on board.
Hi.
Thanks, Doris. Thanks for the update, and always very informative. I had a specific question on Footfall. Because we heard in this committee before that there's probably a contingent in Norfolk and Waveney that knows to use Footfall very well. So my guess is there's quite a bit of a skew on maybe a relative smaller group of patients using Footfall, but then using it very heavily, versus maybe a quite large group which doesn't know about it. Do you have any insights on the level of skew in use of Footfall?
Yes, we do. I mean, this depends. Again, it's a practice decision about whether they go, we call it total triage, or whether they promote Footfall only to a section of patients, or they just allow patients to happen upon it if they go to the website. So there are practices of the same size where there's a difference between 8,000 and 800 forms a month, because they don't, the one with the smaller amount doesn't necessarily put all the traffic through Footfall or promote it. So we do work with practices individually to understand what their particular access issues are and how online consultations can help them. And the practices that haven't implemented Footfall, so we are now allowed to have a range of online consultation systems. So we want to get to the point where we've got 4 or 5 that practices can choose from, and that'll be the subject of our re-procurement. I think we know 50 of the 70 or 80 that use Footfall have feedback that they're very happy with it. Some others are less happy and may appreciate the chance to change. The inappropriate use, I think, comes because it's one of the things we liked about Footfall, everybody that was involved in the evaluation, is that patients didn't have to sign up to it, so they don't have to log into it. But of course, that means that anyone can use it. So some practices do get abused by freedom of information requests or solicitors making approaches to them, and completely inappropriate things going through their online consultation system that they have to deal with. So again, in the future, they may choose to have a system where patients log in, and some of the online consultation suppliers have linked up to NHS login. So if you use the NHS app, it's the same login, and that's going to be a standard across all NHS systems. You'll have one login for anything that you use as a patient.
Yep, thanks, Anne.
Thank you very much, Anne, for the update, and always good to see progress. And we look forward to hearing your next update in a few months' time. Thank you very much.
Thank you very much. Thanks, Chair.
Moving on to the capital grant process. This is a paper for approval. Is it Paul who's joining us?
Hi, Doris, I'm here, yes.
Hi. We take the paper as read. Is there anything you want to highlight?
Hi, everybody. I'm Paul Hyam. I'm Associate Director of Primary Care Estates for the CCG. Paper of presenting today seeking approval of the capital grant process for this financial year and for next financial year. As a single CCG, since our inception, we haven't had kind of a clear process in place as to how practices can apply for grant improvements, and this is kind of the start of that process. So we're hopeful, or hoping, that if the paper is approved today, this can then be the start of a kind of an annual process where we can then refresh every year, and practices can then submit their expressions of interest on an annual basis. Just as members who don't know, the CCG is in receipt of a kind of a business as usual capital funding, which is approximately, historically, has been £2 million per year, and at the moment we've got no reason to believe that that's going to change going forwards, but there's potential variability there. But it's not just estates projects which can bid against that funding, it's also digital projects and LD projects. Historically, estate scheme success against this funding has been low, and we're kind of hoping that having a clear process will make it easier and for practices to apply and be successful in obtaining estates funding. The only other kind of point I wanted to highlight from the paper was the LMC have provided feedback on the paper regarding kind of prioritisation of practices for who would be awarded grants. There is a comment within the paper saying that all practices are eligible to apply for funding, but priority will be given to practices who are engaged in kind of CCG priorities. Historic engagement won't prevent practices from accessing this funding, but any award of grant would be conditional on future engagement, and the LMC have flagged there some concerns around that point. CCG kind of Office of View is kind of noted that feedback, but still feel it's an appropriate section to include within the process. So that's kind of all I wanted to say on the paper, but I'm expecting some queries.
Can I open it up to questions, comments from anybody? John.
Just, I think it's really good, clear process. Really pleased to see we've got it and fully support it. Thank you.
Joni?
Hello. I'd just like to reiterate the LMC's view, and we do support there being a clear process, and we think this is very important. However, we don't feel the linking of the other schemes within it will actually achieve what the CCG seem to be wanting from it. Asking for that additional engagement isn't likely to create the capacity within practice teams to engage in a way they couldn't before. Having estates funding is for your estates. It's not going to therefore create any additional capacity within the clinical teams. It can only be used for estates. So the linking of the two aspects, I don't think will achieve what the CCG are hoping for, and is more likely to put off practices who otherwise would need their estates being developed from going forward for this funding. We do support there being a process, but we think that that section could be taken out to better provide what the estates funding is there for.
Thank you, Jodie. Bill?
Hi, thanks for that. Just something that we, for example, to use the telephony example that we were using earlier on in the previous paper about it being a key sort of front door issue in some practices. Is there any way that we could identify those practices who need this and do a sort of almost pre-filled in form that we could get the practices to use to get some of the a more even front door offer across the place? I mean, is there any way that we could actually get a better uptake and actually focus the bids in a much more targeted way and make more use of this in an area that's been identified as a key issue?
We're kind of governed by the premises cost directions, which are quite old now, 2013. But telephony is an area which isn't eligible for this funding. Installation of a telephone system, installation of a telephone data cabling is all due down to the GP premises to install, and it's not the CCG's or the NHS's liability to install. I think for this year, if we're trying to focus applications, I don't see the benefit of that given the timescale as to where we are in the year. We're keen to see what practices need this year. Because the funding is time limited, we need to get it spent by the end of March. So we've requested EOIs back by the end of October. If we're quick, we could then get them into NHS England in November. If not, that would slip to December, which then only gives them 3 to 4 months to deliver, which isn't that long. If we put in an extra layer of time to kind of working out what we want them to focus on, I'd feel that we've potentially put a risk at the funding for this year.
Interesting proposition from Bill, but unfortunately it's outside the scope as well. And it's about, it's actually getting practices to apply, especially for this year, because it's such a short time frame. But hopefully for next year, there's going to be clarity in terms of the process so that people can think about applying for next year as well. So there's a longer. I do worry that given how busy the construction sector and shortages of material, how realistic is it to actually, even if somebody puts a bid in and it's approved, that the work is going to be done before end of March because of the general what's happening outside in the real world. But anyway, we shall see. John?
Yeah, thank you, Doris. Just responding to Joni's comment, I suppose, in terms of the linkage that we've got in the proposed policy with, I suppose, practice engagement with other initiatives. I suppose, just making the point, I'm keen to see that in there because, for instance, in the prescribing report later, we always look each month at practices that are outliers on antibiotic prescribing or opiate prescribing, or they might be not engaging and switching to cheaper inhalers when they're better value for the NHS, whatever it might be. And actually, I don't see a problem with saying that if we're going to put more NHS money into a practice, in return, we'd like them to engage in some of these programs of work that are either looking to get better value for the NHS or they're looking to improve patient quality and safety, or both. There might also be issues with access at a practice. If a practice isn't particularly engaging, maybe with support, there might be things there that we say, great, we'll support you with a capital grant, but we do need you to respond in terms of looking to improve access for patients. It feels reasonable, I think, to look for those focused improvements in the future. As Paul said, it's not saying, well, you didn't engage with this initiative last year, so we're not going to listen to it. It's about saying, but there are other areas that we would like you to focus some effort on in the future as well.
I think that's, I would agree with you, John, and I think it's also part of the move towards the ICS and actually about systems working. Although GP practices are their own businesses, they are part of the NHS system, and it's a system priority about how we serve the population of Norfolk and Waveney. Hein.
Yeah, I was going to say I'm supportive of the scheme, and also building on what John just said, I'm perfectly fine with that. I've seen it in other industries applied, so I'm well tuned into that approach. I was going to build on your point, Doris, on what you see in the building industry, supply chain issues, and it may be appropriate, and I guess for John to reach out to the region, because this is going to affect some of the proposals that may get approved that simply find it cannot be delivered or completed on time, and it's not a Norfolk and Waveney issue. I think it's a countrywide issue, and you would think the NHS may find some discretion how this timeline is applied. Those were my comments.
Thanks, Hein. Are there any other questions, comments before I ask the voting members whether they are happy to approve the paper as outlined? No. So
I just wanted to come back, if I may.
Sorry, I wasn't sure it was a legacy hand or a...
No, I lifted it up because I wanted to come back. Just, you know, on the issue of areas of more focused. So, you know, I notice on the thing that some telephony works are approved, certainly extending or developing your telephony system is on that list. But I take the point. But the idea of making it easier for specific practices where there's identifiable issues to apply, and therefore encourage greater take-up. And certainly, in particular, you know, if there was a list of projects that were likely to be able to be delivered within the time scale, to encourage practices to focus on those rather than ones with a long lead time, because we haven't got dispensation from the NHS to say that they could be completed in the time frame. So wouldn't it be better to have some guidance to say these are the top 6 things we would recommend you do, and here are the top practices which we think should be doing that, and here is some help applying, just so that we get the most of the money we can out of the opportunity. That's all.
I think in the comms which go out alongside the process, we'll need to emphasise the time constraints of this year, and realistically any bids need to be deliverable, so they need to be kind of the simpler schemes for this year. So I guess we could put in some examples of areas which we think would be more likely to be deliverable, but we wouldn't want to kind of restrict practices to those things, and they should be able to express an interest in a wider range of potential schemes as well. So we just have to be careful how we word that.
Thanks, Paul. I think for next year's scheme there might be a bit more scope for identifying practices that we could reach out to encourage them to participate, because having a wee bit more time to play with as well. So can I just ask the voting members, are we happy to approve the paper as currently outlined? Yep, I got nods from everybody, so that's approved as outlined. Thank you for Paul, and good luck with the rollout. Move on to item 14, which is in communications engagement update. We have a different Paul joining us. Hi, Paul. Over to you.
Thanks, Doris. Apologies if there is a little bit of background noise. I am at an all-day event today, so hopefully it won't be too noisy. But I just want to say hello and thank you to everybody for inviting me today. This will be a regular occurrence moving forward in terms of having a comms and engagement update to the Primary Care Commissioning Committee. And one of the things, one of my areas of focus as part of the new communications and engagement team moving forward is basically, we're just literally at the very end now of recruiting some new multi-skilled officers within the team, and each of those officers basically will look after a specific portfolio. Now, luckily, one of the first portfolios to be looked after and supported is primary care and workforce. So we've now got Paul Martin within our team who's substantively employed to provide that support. So what we are doing basically now is at the very early stages of putting together a comms and engagement strategy for primary care across Norfolk and Waveney. And what will be fundamentally important to that is two things. One is communication and engagement from a patient perspective and members of the public, and making sure that our work so far and work in the pipeline and into the future is right and actually is what patients and members of the public are saying and telling us that are of importance. But two, which is just equally as important, is to make sure that our primary care services, primary care clinicians are absolutely, we're listening to them and we're taking their feedback on board to make sure that communication and engagement messages moving forward do the right thing at the right time and the right place. So just to go into a little bit of detail in the paper, I'll take it as read. But one of the things that I wanted to focus particularly on today was the development of a new primary care campaign that we're in the process of working on. And this particular campaign will basically be multifaceted, multi-channel, and will be focused on 6 key themes. And it won't be a campaign that will just come and go. It will be a campaign that will last over a period of around 12 to 18 months. So there'll be longevity. The messaging will be regularly refreshed, updated with the latest issues or the latest challenges, and indeed feedback from health and care professionals working in primary care and beyond, as well as patients and members of the public. So that campaign will be made up of 6 key themes, and one quite rightly will be about promoting the positive image of primary care. So actually really harnessing on over the last 12-18 months the sheer volume of work that primary care staff and professionals have been doing during the pandemic, and really kind of focusing on some of key stats, information, and that might be, you know, for example, number of prescriptions dispensed, number of phone calls taken, because actually when you start looking at the volume of activity, it is huge. And patients and members of the public need to be reminded of that, because actually, unfortunately, not just in Norfolk and Waveney, but across the rest of the country, there is that perception that primary care has been closed and actually hasn't been seeing patients, and we know categorically that is not true. So there has been pieces of work that we've been doing over the last few months since I've been in post, saying few months now, it does feel a lot longer than that. It is since January, but there's so much positive work that's been done so far, but this really will start to focus on the nitty-gritty. So actually really portraying primary care and its contribution to the rest of the health and care system in a very positive light. One of the other themes will be about zero tolerance. So we know that across primary care and across the rest of the health and care system, there is undoubtedly lots of unnecessary and very offensive, very disturbing information and accusations that are out there. So we will be taking that head on. We've already started to do some preliminary work with some Pcns and working with practice managers to look at some of that feedback, and that will go hand in hand into the campaign and be one of the key themes. We're also going to be looking at the variety and depth of primary care roles. So there are quite a lot of myths out there where people say, I can't see my GP, and they'll only talk about their GP. So one of the key areas will be to focus on the depth of roles across primary care. So our pharmacists, our clinical pharmacists, clinical practitioners, advanced nurse practitioners, care navigators, practitioners. So really focusing on and educating and kind of tackling some of these myths that do exist out there, to actually try and get it into people's heads, quite rightly, that if people do say, I can't see my GP or I want to see my GP, well, actually, sometimes your GP is not necessarily the right person for you to see. So that will be about the encouragement and bringing out some case studies, doing videos with various different health and care professionals to really showcase the different roles across the system, particularly within primary care. We'll also be focusing on digitalisation, so we are focusing on that, and this furthers to the update that Anne spoke about earlier, but talking about some of the ways that people can continue to interact from a digital point of view, so booking appointments, and all the different range of digital interactions that people can have with primary care. And where challenges do come up, actually taking that information and bringing it back into the campaign and addressing some of that. Self-care is going to be another key important factor of the campaign, and making sure that we link up with medicines management colleagues, in particular Michael, and other colleagues, to actually bring out the fact that people should be empowered to some degree to take control of their own healthcare and support us in our direction to try and get people to self-care wherever possible. And then finally, linking up with the rest of the health and care system, there'll be a choosing the right service theme, and that particularly will really focus on examples of how to use primary care service as well. Equally, pharmacists, and basically making sure that we try and do all we can to not only promote primary care and the services that do exist as we transition into the ICS, but also with that quite right importance of making sure that if people do, for example, go to A&E, they go into A&E for the exact reasons that they should be going, because it's absolutely life-threatening or an absolute emergency. So I'll stop there because I've spoke for quite some time, but I'm happy to take any questions. So yeah, thank you.
Thanks, Paul. It's really good to see you know, there's now sort of a roadmap of things on the horizon, because we've talked about this, you know, for quite a few months now, and obviously earlier today as well. Kathy, did you want to come in?
Yeah, thanks, and thank you for this. It looks really, really interesting and important. I had a couple of comments, really. I guess the first one is it struck me reading some of the narrative on Twitter, particularly regarding GPs, that we spend a lot of time explaining to the public what other roles in the primary healthcare team do, but we probably ought to spend some time explaining what a GP does. Just because there's a narrative, you know, about, you know, can get rid of them and just have hospital doctors and all this kind of nonsense. You know, it just struck me that a really good story about why general practitioners are so important to the healthcare system would be something that we should also focus on. And then the second one is that within a social media strategy, there's an expectation that your people will tweet things for you. So I had an unfortunate experience a couple of weeks ago when I shared a post from the CCG about vaccinations, and commented that I'd been proud to be part of the children's vaccination service, and unfortunately got a few anti-vaxxers offering me death threats and Nuremberg trials and this kind of thing. And it just struck me that for people who are already under a lot of pressure, that could be quite unpleasant. And so do we also have something from the CCG whereby we can support people or give them a line whereby you can stop some of these maniacs constantly kind of following you around the system, really?
Thanks, Kathy. They're really important points. So one thing particularly is that we are also developing a brand new social media policy for the CCG that we can easily and very rightly share with primary care in response to that. We have seen, obviously, as you would expect over the past few months, quite a few anti-vax comments that keep coming our way. And unfortunately, they are very unhelpful. And do try, you know, yes, people are entitled to their opinion, but from an NHS perspective, if they are either derogatory, negative, or aimed at staff, we are now starting to either block those individuals or simply delete those comments. And actually, sometimes a comms professional may think, oh, don't do that, we shouldn't really be doing that. But actually, this is kind of going against what we're trying to do as a country. And unfortunately, that sort of abuse will not be tolerated. So yes, in short answer, there will be something that we can share imminently with primary care and indeed other healthcare professionals.
Thanks, Paul. Naomi?
Hi, yeah, so I just wanted to say thank you, Paul, for that update. It's really reassuring to hear all this work that's taking place. We have had conversations with the CCG to date on these topics, and have also had a really good meeting with Healthwatch about what sort of joint communications the LMC and Healthwatch, and would welcome sort of involvement from the CCG as well if similar pieces of work are taking place, because we feel it's really important that the system as a whole is all on the same page and giving the same messaging. So especially if patients were either choosing to make a complaint to the CCG or to PALS, that they fully understand why the system's working the way it is, what constraints it's under, what appropriate healthcare looks like, but also to enable us to not shy away from addressing issues where there are issues, because there are patients that potentially are struggling to access healthcare. But it's about making sure we're looking at what are genuine issues that need addressing and separating that out from what are either totally inappropriate patient abuse, which is not tolerable no matter what the issue, or if they're things that are just a misunderstanding of the system. And certainly a piece of work we are looking into are things like practice websites, which a lot of them are centrally designed but are actually quite user friendly, and a lot of patients have never really had any information on how they can use the systems, how they can either book an appointment or contact GPs. And there's bizarre terminology like the words consulting room, where patients would go to speech to. So they're quite simple things, but actually could really help. And if we can help the people that can use digital technology to use it, it's hopefully going to free up phone lines and patient access for those that need that method. But also reiterate Kathy's points, is that there's abuse happening all over the show in general practice, and actually social media is almost another avenue that patients are now using to direct their often very inappropriate and hurtful comments to general practice. And there does need to be a level of understanding that it's zero tolerance no matter how you're abusing practice staff. And I think the culture that we now live in is that Twitter is seen that a lot of inappropriate comments can be made, and that now seems to unfortunately be the nature of Twitter. But definitely a message out to the public that the same rules apply for social media, reinforced by the CCG, would be really welcomed.
Thanks, Naomi. Tracy?
Yeah, thank you, Paul. It's really welcome to have this as a strategy going forwards, and certainly reiterate colleagues' comments as well, and support kind of, how we kind of manage that social media and we kind of protect kind of, colleagues from abuse, because it can be quite abusive and quite targeted. So really keen that we give our support for that. And I think, generally in primary care, we don't have the infrastructure to really kind of, do those media approaches that we'd want to, but certainly with larger provider organisations, they have that kind of teams behind them. We don't, so this is going to be really helpful, I think, and supportive. Particularly interested in some of the engagement work as well. You mentioned PPGs, but really keen in respect to some of our most underserved communities, and how we reach with some of the, the understanding, the messaging and supporting, I think is going to be really key. So very keen to become involved and help with that work, because I think it's going to be, essential going forwards. We are going to address inequalities.
Thank you, Tracy. James?
I think there's some good work here, and I appreciate all the work that's going into it. The one thing I would like to emphasise, though, it is not the shouting, abuse or bad language that has the biggest impact. It is the well-spoken sarcasm. It is not treating people as respect. It's the almost best summarised as "don't you know who I am?" And that's what leads to real upset or people in tears at my surgery. If you've got somebody who's in distress and they're shouting, it's because they don't know how to cry, or they don't know what you want to help them on the whole. Where somebody feels that they've got a right to an appointment in 24 hours because they're better than anyone else, and they make the receptionist feel foolish and stupid and weak because they can't offer that. That's where the real upset is, and that's the journey and challenge that we've got to take certain patients on. And I think that's the, I've just come back from leave, and there's a few people, and it just is, people have accumulated complaints, and it's this aspect of, you're running a really poor surgery because you can't offer me an appointment in 24 hours. and you know, over the weekend we've got people like Alison Pearson. Did you see that thing in the Telegraph that said if GPs went on strike, who would notice if they were gone? Just awful, and people reflect that back at us, and so it is a real challenge. So it's good to have all of these messages going on, but I think for me, zero tolerance is about that level of entitlement and sarcasm, and that's where, you know, an insult of the mind is much more lasting than an insult of the body, and that's what I'd say.
Thanks, James. Fiona.
I really just wanted to say how much we've welcomed having the focus in Paul's team on primary care. It's been really, really helpful over the past few months. And, you know, some of these important messages and the campaigns that Paul's talking about obviously are really important as part of some of the policy and development of plans around access that we're trying to put in place. And so I think there's an important piece of work that we are already doing, but we can, I think, improve upon, which is bringing Paul's team, the digital team and primary care together to look at really how we can use all those tools to hand to help and support practices. And that's what we'll be doing over the next few months or so. But just want to say thank you to Paul's team.
That's
Thanks,
great.
Fiona.
Bill.
I think this is an excellent piece of work, and I just really wanted to say that this is not just in primary care. This is happening across council workforces, and there's this sense of very aggressive entitlement in the population at large, and I see it even in parish council meetings where everybody is there for free as a volunteer. And some of the behaviour and abuse at parish council meetings is, you know, to people who are giving up their time for nothing, is most unpleasant, and it seems to be a sort of national issue. I don't do social media anymore because actually it's quite counterproductive and you spend a lot of time. But I think I didn't want everybody in primary care to feel that they were being targeted. I think there's a general malaise to do with the social media generally. People don't think before they speak, and then when they meet people in public, they treat them as if they were dealing with them online, which is a shame. So anything we can do to alter expectations, and there is work that the county council is going to be doing to try and do this as well. You know, people getting abuse over such trivial items as getting grass cut and stuff like that. It's a national issue, and I'm very sorry for everybody who has to face it.
Thank you, Bill. I think civility does not hurt, and I think we need to bear that in mind in all our lives. And I think we all have moments when we lose it, but actually to apologise because as well. So thank you, Paul, for the update, and we look forward to seeing some sort of hopefully move the communication forward so that there's a better understanding of what is happening in primary care, especially the different roles, to reduce the sort of stress and strains that people on the front line are facing. So thank you. Moving on to the prescribing report, Michael. I've really lost my. You're very crackly, Michael. I can't really hear you.
I've got a power cut here. So.
Oh no. shall we move on and come back to you if your power is restored, or you start?
Yes, please. Yes.
Yeah, you need to start running on the spot to get that generator working.
Oh, I know.
That's when we'll come back to you, and hopefully your power is restored.
Okay.
Thanks. On to number 16, which is the CQC report on the Beaches medical practice. I think Carl's joined us for that one.
Thanks, Chair. Yes, I'm very pleased to bring this report to the committee. The Beaches, previously rated as requires improvement following a CQC inspection in November 2020, which introduced special measures and urgent conditions. The practice were re-inspected on the 22nd of July 2021, and the outcome of that was rated good with the following areas: safe, effective, caring, and responsive, all rated as good. However, well-led was rated as, again, requires improvement. The CQC highlighted the amount of hard work the practice had put in, and they have been supported by Steve and Imran as an extra resource to aid the practice through the reports. I'd also like to give a special mention to the quality team, meds management team, and the locality team as well for supporting the practice as well. And the locality team will continue to support the practice in terms of the areas still rated as requires improvement. And I've listed them in the report. And the main emphasis is on and around making sure the staff are given time and support by the GPs to enable them to carry out their duties. Again, we'll be looking for the meds management team to provide support in regards of certain prescribing areas, and also the quality team for the introduction of the care plans, etc., as highlighted, and the improvement in the uptake of cervical screening. So very good to hear this report, which is good.
Thank you, Carl. Are there any questions for Carl? Kathy.
Thanks, Carl. I mean, it's really good to see the improvement, and it makes me wonder, therefore, because they have improved, when will we be looking at this again, or will we? Because in many cases, the reason the practice is marked down on an area makes me kind of go, it's a policy or a locked drawer or something of this nature. In this case, it's the staff. And we've already talked about, staff being under considerable pressure. If they're also not feeling valued and supported within their own team, then that seems to me to be quite serious. And I wouldn't like this to slip off our agenda as a consequence.
It remains on the practices at risk report, so it will be reported, yeah. We'll continue to look at it and provide support through the locality team to ensure these areas are improved upon.
Are there any other questions? And presumably in the report it also will pick up in the future the issue around the QOF data, because in your summary it says that the practice is performing below the sort of average.
Yeah. Sorry, I just picked out some highlights there, Doris. That will do, yes.
Thank you. If there's no other questions, thank you, Carl.
Thank you.
We move on to the finance report for noting. It's James taking this one.
Yeah, that's correct. Thanks, Chair. I'll take the report as read, but just go through and draw your attention to the major points and take any questions after. So starting off with the half two budget indications, at the moment it's looking like there'll be up to 5% efficiencies required, and work on savings within prescribing and delegated primary care have started, and possible savings identified.
Can I just stop you for a moment,
Yep.
James? Carl, could you just turn your microphone off? Or Sarah, to mute everybody, and we can unmute ourselves. Brilliant. Carl turned him off. Thank you.
So engagement with the meds management and primary care teams are ongoing to ensure that there are sufficient savings to cover this up to 5% requirement. Moving on to the overall position on the financial summary, we're showing a favourable variance to budget of 1.3 million at the moment. This has actually worsened from month 3 to month 4, and the majority of this movement is within GP prescribing. Moving on to the detailed variance analysis, the GP prescribed movement can be seen due to the underestimate of the May actuals. These estimates include significant estimates of ongoing savings which have not crystallised. The other areas of significant variances within the delegated costs. These are clawbacks due to the walk-in centre footfall contract in Norwich and other reductions in rent rates and locum spend. Moving on to the COVID capacity fund on page 6. So this is a major payment that we've been making at the moment to practices. So we have a budget of 2.32 million to pay out, and as to date we've paid 1.92 million of that fund over. Moving on to the system development fund, formerly GP Forward View. At the moment this is not showing any variance to budget and is anticipated to remain so. Detailed look at the delegated cost centre. So in addition to the walk-in centre estates and locum benefits, there is a cost pressure within QOF at the moment. This is due to a late notification of 2 of the indicators moving from NHS England funding to the CCG's baseline, and there was no specific funding for them, which has caused a cost pressure for us. Within GP and other prescribing also, at the moment it's following the same pattern as previous months, where the prior year benefit is being offset by efficiency savings not crystallising, as mentioned before, plus favourable variances within dressings and oxygen. The financial risks remain the same as month 3. So are there any questions?
Thanks, James. Questions from anybody? No. Thank you very much. And yeah, I'm not surprised that the sort of prior year benefits is being eroded into. So disappointing still. So thank you. Now, I don't know if Michael has managed to restore his power.
Hello, Doris. I'm here. Can you hear me?
Yes, we can hear you.
Okay, I have one bar on my mobile phone, so I'm just voice only. Should I start? Let's just go through the paper. So I'll take the paper as read, and I'll try and be quick just in case the signal doesn't last out. Just a few things to highlight. Our greener inhaler campaign has gone live, poster campaign and media, etc. And we've allocated a couple of technicians who will be offering some support to practices to work with their local pharmacies to get to prime the work so that we can get this done quicker, because as well as improving the environmental impact of inhalers, it will actually save us a bit of money at the same time. So we're quite keen that we do this, and it should be quite an easy project once we get it off the ground. Disappointingly, NHS England has taken the decision not to proceed with in-housing, so we're looking at filling some of the vacancies that are significant vacancies that are in the CSU, and we're hoping we're not going to lose any more staff to Pcns who are advertising for people who within our teams who could jump ship to join that workforce. Looking at our spend compared to the east of England, we're 5th this month. We were 4th last month, so a slight improvement. Next month, I think I'll map this to deprivation scores, because mostly it goes with the deprivation scores, apart from a couple of exceptions. Perhaps that's worth discussing next month. In terms of year-on-year spend or growth increase, there's the usual suspects in our section just before section 3. So there's the DOACs, etoxaban, which is our preferred DOAC. Freestyle Libre 2 has crept in, but that's an artifact of the way that we are moving patients from Freestyle Libre 1 to Freestyle Libre 2. So there was no spend last year. So in theory, that should be reasonably cost neutral and will actually save us some money elsewhere, because patients shouldn't have to use standard blood glucose testing with Freestyle Libre 2 so much, certainly. And disappointingly, there's some increased costs due to global markets on some commonly used drugs like cocodamol, paracetamol, torvastatin, and aspirin, would you believe, which is causing us several hundreds of £1,000s worth of cost pressure. Dependence forming medicines, paper is going to KEC, Clinic Exec, next Tuesday. That's been delayed due to agendas being full and holidays, etc. And we're developing an action plan as a system to work on this. There's been a little bit of change. We've moved from 99th percentile nationally to 98th percentile nationally on hypnotics and anxiolytics, but still at 3rd position. Others are fairly similar. For the month, there is a reducing trajectory on those, the anxiolytics, etc. Antibiotics, we've visited some of our higher prescribing practices. There's a couple of practices who we've identified who we yet to visit, who we'd like to chat with about their prescribing. It's likely that in August data we should see some significant improvement in our top prescribing practice of broad spectrum antibiotics. It's not likely to occur till August because of the phasing. And then we've done a breakdown of PCN achievement in last year's PQS. So 65% of total which is quite a significant amount, and most practices engaged with it and payments. There was a disappointing turnout, and some practices didn't engage, in one PCN only got £500 odd in terms of payment because of not sending in any evidence that they'd done any work in the area. Happy to take questions.
Thank you, Michael. Are there any questions for Michael?
Okay.
John?
Just a brief comment, Michael, I think you made the point earlier on about the business case for the in-housing of the CSU services. Just to say, I haven't had a chance to catch up with you, Michael. We haven't had final confirmation of the outcome of that business case yet, and my understanding is that there are still discussions ongoing. So the position you presented in your paper might not be quite the current position.
Oh, okay, okay.
I'll keep you posted outside of this meeting.
Might not be as up to date as I would like. Okay, sorry for that. Okay.
Yes. And Chair, apologies, I need to disappear now. I've got another meeting at 4, so I do apologise.
Thanks, John. So it's good to hear that the decision isn't final. So hopefully we'll get a favourable outcome. Are there any other points for Michael? No. So thank you, Michael, for hanging on in there with your lack of electricity. So
yes.
We're on to the last item, which is any other business. We actually have a question from the member of public as well that was sent in beforehand in relation to the deaf patients and using technology to access primary healthcare appointments. I think Fiona is going to be looking into, she's actually contacted the NHS ENI to get some more information before we can make a formal response back to the person who's raised the question. Once that has been finalised, the question and the answer will be on the CCG website for others to see as well. That was the only question I'm aware of, unless anything has come in the interim.
No, nothing at all.
Thank you, Sarah. Is there any other business from anybody? No, thank you all very much. I'm sorry I've overrun with timing, but it was good to have the discussions on the various bits of the paper. I thank you all for your time this afternoon. For those who are coming back for part 2, can we reconvene at 4:10, so you can have a comfort break and get a cup of tea. I will see you all, those who are participating